Over the past 50 years, emergency care has come a long way. 1970 was a monumental year for our specialty. It marked the founding of the first emergency medicine residency training program in the United States, and also the establishment of the Emergency Nurses Association. We are a specialty of dreamers and doers. We have grown from humble beginnings as a single room in the hospital's basement into full-fledged departments that serve as the front door to the hospital and the front porch of America's medical home. We provide care to more than 140 million patients each year and have transformed America's acute care system. 50 years from now, emergency medicine will be as different from today's specialty as we are from our 1970 roots.
Good morning, Mr. Smith. Today is Friday, September 11th. The year is 2070. Let us please take a moment of silence in observation of Patriot Day. Today's weather includes partly cloudy skies with a chance of showers in the afternoon. The high temperature will be 73 degrees and the low will be 54 degrees. I have reviewed the vital signs captured by your smartwatch throughout the night and noticed that your heart rate and respiratory rate have been steadily increasing and your oxygen level is low. How are you feeling this morning? Would you like for me to call for medical assistance?
A moment later, the hologram of an emergency care nurse, Eric, appears. Eric works in the telemedicine care hub of the Regional Emergency Center. He has taken dozens of calls this morning from patients like Mr. Smith, many of whom were able to be completely treated virtually, and some of whom were referred directly to non-emergent care locations.
Hello, Mr. Smith. My name is Eric. It's great to see you. Sorry you aren't feeling too hot. It looks like your vital signs are going in the wrong direction. So let's take a listen. Please place your smartphone on your chest and take some deep breaths. Your heart sounds are normal, but it sounds like you might have some fluid in your lungs. I've recorded your breath sounds and breathing pattern for the doctor to review. These sounds can be caused by a wide variety of conditions. So let me take a look at your health data more closely.
Mr. Smith is a 72-year-old male with a past medical history of diabetes, hypertension, congestive heart failure, and COPD. He is a former smoker. He has had a progressively worsening cough over the past week, and last night his smartwatch recorded him becoming progressively more tachypnic, tachycardic, and hypoxic. Based upon his age, comorbidities, and current vital signs, there is a 74% chance that he will require hospital admission at this time. His 30-day mortality is predicted to be 34%. His social determinants of health include limited income, poor access to healthy eating options, and living in a neighborhood that has poor walkability and limited transportation options.
I've conferred with the telemedicine AI bot, and we recommend an in-person evaluation in an emergency department. I'll go ahead and contact the emergency nurse call center and make the arrangements for you to be seen.
With the push of a button, the emergency nurse sends a notification to EMS requesting transportation. Mr. Smith is able to track the location and estimate time of arrival of his ambulance while it's en route. When EMS arrives on scene, they have a complete, up-to-date history about Mr. Smith sent in from the emergency department at the time that transportation was requested.
Once Mr. Smith is comfortably inside the ambulance, EMS starts their assessment and inputs it into the computer. With real-time information on wait times and the capabilities of all of the local facilities, the computer starts to calculate where Mr. Smith would be best served. Your primary care doctor has an open slot to see you in 30 minutes, but the AI bot thinks you need a higher level of care. And based upon our EKG and our handheld x-ray, we agree. But since the closest hospital is pretty busy, and the local freestanding is on standby because of a large concert gathering in the area, we'll take you to the micro-hospital one town over. And just like that, the self-driving ambulance is on its way.
Before Mr. Smith even arrives at the emergency department, he's been pre-registered, and his vital signs, 12-lead EKG, history of present illness, and X-ray obtained by EMS have been uploaded to the micro-hospital's electronic health record. Dr. Casillas, a board-certified emergency physician, reviews these prior to his arrival, and a 3D ultrasound of his chest is ordered based upon a concerning opacity seen on the pre-hospital chest X-ray. When Mr. Smith arrives, he bypasses the waiting room and is met immediately by the ED ultrasound technician who's been waiting for him. 20 minutes later, Dr. Casillas enters the patient's room and sits down on the side of his bed.
Dr. Casillas is a first-generation American who comes from a blue-collar family with limited financial means. She may not have had the opportunity to attend medical school in the 20th century, but by 2040, it had become significantly more affordable. Funding from local counties and states exists to produce physicians who will serve their communities, thus eliminating the physician gap across the U.S. Medical residency and nursing programs have also dramatically changed, transitioning from time-based to competency-based curricula, resulting in training lasting a variable number of years. Mr. Smith, it's a pleasure to meet you. Are you feeling any better without oxygen on? Good. Well, I'm afraid I have some bad news. She reaches out and holds his hand as she updates him on the findings of the imaging, a new lung mass and a likely malignant effusion. At the same time, a virtual natural language processing scribe documents their conversation, codes the encounter, and submits it to a national electronic health record for reimbursement and quality measurement. She is automatically prompted to place orders that had been previously placed for patients with similar presentations. Despite all of the technological advances the past 50 years have brought, the emotional toll of telling a patient that they likely have cancer hasn't changed. They each grab for a tissue. Though the news Dr. Casillas delivers is heartbreaking, it's another example of the human connections made and compassionate care provided every day in emergency departments around the world.
In our imagined future, emergency departments have changed significantly since 2020. Technological advances like artificial intelligence, remote patient monitoring, and telemedicine have increased access to care, particularly for underserved patients, leading to earlier detection of life-threatening illnesses. It's also allowed for more precise triaging of patients prior to arriving at the emergency department. Board-certified emergency physicians can perform medical screening exams remotely and schedule patients to see their primary care physician or a subspecialist if more suitable. The reimbursement landscape and the business model of emergency medicine have finally adapted to the world of value-based care, and emergency departments are actually being reimbursed for sending lower acuity patients to alternative care locations.
Perhaps the biggest change has been the elimination of most inpatient general medicine beds in America in favor of providing acute care in the home. While hospital at home was invented in the 1980s, it wasn't until the 2040s and 50s that it became commonplace. Specifically, robots were developed that made doctors, nurses, and techs' lives easier by starting IVs, administering medications, and restraining and watching and walking patients. And reliable drones were created that could then transport labs and medications back and forth. Additionally, remote patient monitoring through smart devices allowed care teams to monitor patients in the home just as reliably as they were once monitored in ICU settings. But these changes were only possible because of a new trend in nursing: home ICU and acute care nursing, where highly trained nurses were able to provide high-quality care right in patients' homes.
Back in the micro hospital a few hours later, Mr. Smith's clinical status starts to decline. He becomes more tachypnic and hypoxemic. The smart ultrasound wheels itself back to meet Mr. Smith in the resuscitation bay. The AI software notices a dilated right ventricle and a reduced TAPSE, consistent with pulmonary embolism. Prior to intubation, Dr. Casillas checks Mr. Smith's advance directive through the National Next Generation Health Information Exchange. She also updates his family members who had subscribed to his real-time care feed. A few minutes later, he codes. The emergency care team initiates ECMO and pushes TPA nanobots, which had replaced the need for intravenous thrombolytics and catheter-directed thrombolysis. Initiating ECMO on a 72-year-old had become routine since the mid-2040s, when life expectancy surpassed 100.
Based on his need for dedicated PE and ECMO teams, as well as local bed availability and risk-adjusted patient outcomes data, it is determined best to transfer Mr. Smith to a specialty hospital 100 miles away, bypassing the local specialty hospital. A minute later, he is loaded into an ICU drone equipped with tele-ICU capabilities and a critical care proceduralist and whisked away. Because of the efficiencies of transferring patients to the nearest open bed with the appropriate resources, rather than the closest hospital or the hospital that just so happened to be connected to the emergency department, the word boarding has been relegated to back in my day stories.
This futuristic thought experiment highlights two unique business models. First, microhospitals, and second, specialty hospitals. In the emergency medicine world of tomorrow, specialty hospitals, generally one every 100 or so miles, formed because the evidence showed that doing more cases in a specific specialty made you learn more and achieve better patient outcomes. A mix of academic medical centers and corporations raced to consolidate this hospital market in the 2030s and created these 5,000-bed megaplexes of specialty healthcare, just like Walmart and Amazon had done in the retail space during the early 2000s. But Americans still needed access to acute care within a reasonable distance from their homes, and so the microhospital was born. Part freestanding emergency department with resuscitation bays and imaging in-house, part observation unit, and part heliport to efficiently ferry critical patients in specially made ICU drones to the hyperacute specialty hospitals. These centers proliferated, with emergency care teams at their helm.
While our specialty will evolve dramatically over the next 50 years, the need for emergency physicians and nurses will only continue to grow.
Tomorrow's emergency physicians and nurses will build upon the giants who founded emergency medicine. Their job description will be more than just resuscitationalists who bring people back from death's doorstep. Instead, they'll also be diagnosticians who can make sense of all the noise generated from enhanced triaging and remote patient monitoring, and availabilists who see patients 24/7, 365, and dispositionalists who quarterback care in an increasingly hyper-specialized system.
Most importantly, in an ever-virtualized world, they'll serve as the humanists who can spend extra time sitting down and talking to their patients, bringing an element of sanity to the chaos that is 2070.